In jury members, Bhakti ma'am has joined and Varsha ma'am has joined,
Mhm. Yeah.
and Mithali ma'am will be joining within a few minutes, ma'am.
Yes, we'll wait for Mitali and then we'll get started, Raju. Who's admitting people? I see in
Mrs. Sai, Mrs. Sai is admitting. I'm admitting, ma'am.
okay. Yes, I see people in the waiting room. So
Okay, just a moment. I think Varsha has logged out from the meeting. Her screen is completely blank. So I think we can just wait for 2 minutes for her to log out and log in again. For Varsha also, there is some technical issue. She just messaged me.
okay, Bhakti, we'll just give her a few minutes. We technically have few minutes actually, so we'll just wait.
Yeah,
Sai,
sure.
can you call Varsha to see if we can help her? Is Varsha on? Mithali, are you on?
Yes, I'm on.
Thank you so much. I think we are just waiting for Varsha. Sai, can you just call her to see if she needs any help getting onto the Zoom?
Yes, ma'am. Just a couple of minutes. Wait a minute.
All right, okay, that's fine. So while we are waiting for our jury members, I would like to request all our presenters of the case studies today to just be ready. Mr. Sai will be presenting, sharing the screen. So you'll see your presentation. I'm sure you got a background, but just wanted to give a heads up. You'll see your presentation. When you have to go to the next slide, just make sure you tell them to change the slide and he will do that. We're doing this to avoid any technical glitches on your end. And each presenter will have about 12 minutes to do the presentation and the 3 to 4 minutes for question and answers from jury members. Okay. So please be ready with your presentations and we will get started as soon as our jury member, Ms. Varsha, gets on the call. So the order in which we will go for the presentation, for the presenters, please be mindful. First is going to be Ms. Maheshwari, and then we will have Drishya's presentation. Then we will have Sai Darshini, then Anita James, and last is Amrita. So please be ready to do your case study presentations. We'll get started just in a minute now, as soon as our last jury member gets on. Varsha, are you on? Varsha? Okay. Can somebody admit all these people? She's been in the waiting room, I guess.
I've joined.
Okay, great. So we have our jury members. Varsha is on. Mithali, are you on?
Yes, I'm on.
Great. And we have our other jury member, Ms. Bhakti. Are you on? Just making sure that we are all on here before we get started.
Yes, I am there.
Okay, perfect. Thank you so much to all our jury members, first of all, for joining us today. I know it's a busy work day, and you have taken your valuable time to be with us. Thank you. Welcome everybody to Pulse NutriQuest National Case Study Contest. We have been doing this case study contest on NHF platform, NutriHealth Foundation platform. And this event is sponsored by Pulse NutriScience. I would like to extend my warm thank you to the entire Pulse NutriScience team for coming up with this great idea of having a national case study presentation for all the dietitians across the country. And we have had tremendous response last month. And there were a lot of wonderful and insightful presentations that we did last month. And this month we are having 5 presentations today. Again, they're all very insightful and I'm sure you all will love it. So the way we are going to do this is I'm going to introduce our jury first, and then we will go on to the presentations. Each participant is going to have about 15 minutes, out of which 12 minutes is for you to present your presentation, and then you will have 3 minutes for taking any questions by our jury members today. So first, I would like to welcome Ms. Mithali, our first jury member. Thank you
Good
so
evening.
much for being here with us. Mithali is a chief dietitian and a quality head at Peerless Hospital in Guwahati. I just had a very insightful discussion with her. She has a lot of things wonderful things that she is doing in Assam, and it was very impressive to hear all those stories from you.
Thank you, Dipti.
Yes, just to give a little brief introduction about Mithali, she has about 23 plus years of experience in clinical nutrition, hospital dietetics, and quality systems. Currently, she's a chief dietitian and quality head at Peerless Hospital in Guwahati, and she was a former head department of nutrition and dietetics at Ayush Sundra Super Specialty Hospital in Guwahati as well. Mithali is also a specialist in critical care nutrition, diabetes management, renal nutrition, and lifestyle counseling. She has extensive experience in setting up dietetics and food and beverage departments in various hospitals, developing SOPs and NAPH compliance. Not just that, in spite of doing all of those, she is a very active speaker, chairperson, and judge at many national level nutrition conferences. Thank you so much, Mithali, for being with us
Thank
here.
you, Dipti, for
I
giving a
appreciate
wonderful.
your time. So our presenters are excited to share their case studies in front of you.
Yeah, sure.
So next we have Varsha Gore. Varsha, thank you so much for being with us today. Again, Varsha is another senior clinical dietitian and head of the department dietetics at Apollo Hospitals, Navi Mumbai. About 25 years of experience she comes with in nutrition and dietetics, including 15 years in multi-specialty hospital settings. That's amazing. She is currently a senior clinical dietitian at Apollo and a chapter secretary with the IAPEN, Navi Mumbai, and also a member of IDA, IAPN, NSI, and ISPEN as well. Coming to the academic credentials, Varsha is MSc in Nutrition and Dietetics. She has about 14 subject modules of LLL certification by ISPEN. That's amazing. It's a lot of time that you spent. That shows your dedication towards critical care nutrition, Varsha. She's also certified in FODMAP diets from Monash University, and she did her research and ethics certification from St. John's Institute in Bangalore. Varsha also got an IAPN India Quality Award and State Award for Excellence in Medical Nutrition Therapy. She got awards for Therapeutic Food Service Management and Digital Documentation. She contributed to many journals, many journal articles in SPEN and IAPN publications on dialysis and onconutrition. And she also added and authored chapters on clinical nutrition in many books on GI disorders, PCOS, sugar substitutes in cancer, and neurological diseases and nutrition. Thank you so much, Varsha, for being with us here in spite of your busy schedule. We really appreciate on behalf of NHF you taking time and joining us today. I hope you'll enjoy all the presentations.
Looking forward to. Thank you.
Sure. So coming to our last but not least, our own Bhakti Samant. Welcome, Bhakti. Thank you for being with us here today. Again, in spite of being a very busy dietitian, Bhakti Samant, she's a chief clinical dietitian at Kokilaben Dhirubhai Ambani Hospital and Research Institute in Mumbai. She comes with about 20 years of extensive experience in clinical nutrition with expertise in critical care, oncology, nutrition, bariatric diets, and metabolic disorders. And she is our Honorable Joint Secretary of IAPN Mumbai chapter, and she's a Chief Coordinator of IAPN ISPEN Training Center, KDAH, and also a ISPEN LLL teacher. Bhakti is got her European ESPEN Diploma in Clinical Nutrition. She's certified in low FODMAP diets, ketogenic diet, bariatric nutrition, and body composition analysis. And she has many awards that she has received as well, out of which she got multiple awards, including Dr. Tarita Shankar Award for Excellence in 2025, Healthcare Leadership Award in 2025, IAPN Excellence Awards in Nutrition Research in 2025, Medical Nutrition Therapy in 2023, and Therapeutic Food Service Management Award in 2021. Not just that, she's winner of many national and international presentation awards, including at PENSA 2024 and Vishwatyam in 2024 as well. She's published in Journal of Nutrition Research on cancer, I'm losing my words today, cachexia and oncology nutrition. She authored chapters in clinical nutrition in cancer, IAPN India NCP book, and many more. Not just that, she has submitted multiple abstracts that are published in international journals such as ISPEN and PENSA. That's a lot of achievements and publications and awards, Bhakti. Thank you so much for being with us. All our presenters are super excited to present their insightful case studies in front of you. So now we will move on to the presentations without any delay. Also, before going on with the presentations, I would like to thank our special friend today, who was also, and guest today, who was also here, Esther Satiraj. Dr. Esther, thank you so much for being with us. It's always nice to have you on these presentations, and I'm looking forward to hearing more about these presentations from you.
Thanks, Dipti.
You're welcome. So we will go ahead with our presentations now. The first in the row is Ms. Maheshwari. Sai, could you please share your screen and pin your screen so it doesn't change? And Maheshwari, please keep your video and audio on and go ahead and start your presentation. I will let you know when it is 12 minutes. Like I said, you have 12 minutes to do your presentation and 3 minutes for your question answers. So please make sure you're sticking to your timeline so others get fair chance to present their case studies as well. Right? Your time starts now. It's 4:10. And I'll remind you when it is 12 minutes. Go ahead.
Hello?
Yes, Maheshwari, we can hear you. You can go ahead and get started.
Yeah, okay. Hello?
Yes, we can hear you, Maheshwari.
Yeah, hello. Myself Maheshwari. Today, am I audible?
Yes, you are audible and we can see your presentation. You can go ahead and get started.
Okay, okay.
Yeah.
Okay, okay. So, today my topic is nutritional management. Can you please next slide? The first one. Hello? Yeah. So this presentation details a case study focusing on the critical role of nutritional management in a patient with diabetes mellitus who underwent an ebony amputation due to gangrene. So we will explore the assessment, intervention, and outcomes, like highlighting the importance of integrated care. Next slide. So my case study, patient identification and clinical context, like patient demographics, like age 62 years, and anthropometry, like height is 170 centimeters. And so the patient presents with a history of poorly uncontrolled diabetes, like patients. And the clinical presentation diagnosis is left leg gang. And the procedure was left knee above amputation has done. Critical nature of the patient's condition.
Maheshwari, can you please speak up? Your voice is not very clear.
Yeah, okay.
Please speak up. Yeah, come close to the mic and please speak up.
Okay. This contest underscores the acute nature of the patient's condition, requiring immediate and comprehensive care. Next slide, please. The relevant clinical information and laboratory parameters. And the medical history, type 2 diabetes poor control, and he is a hypertension, commonly comorbidly exacerbating vascular issues, and PVD, peripheral vascular disease, directly contributing to gangrene development. And his key laboratory findings, his HbA1c is 9.5, albumin 2.9, and CRP is 22, creatinine is 1.6. These values collectively indicate severe hypoglycemia, malnutrition, and systemic inflammation. Compromised renal function, all critical for recovery. Next slide. comprehensive nutrition assessment, extent of malnutrition, and its contributing factors. So these are all the 6 factors like weight loss, biochemical markers, functional status, anthropometry,
Maheshwari,
dietary.
just a quick second. Maheshwari.
Hello? Yeah.
Yeah,
Yeah.
looks like you are logged in from a phone. If you could just keep your phone stable and not move it, that'll be, yeah, that will avoid a lot of distraction from the screen. Yeah, just keep it at one place and make sure it's not distracting.
Okay.
And just a quick note for the next presenters, please make sure
Yeah.
your devices are stable and you are in a place where there can be little bit of, no distraction. So
Okay, sure.
it's audible for everyone. Okay? Maheshwari,
Yeah,
please
yeah.
move that screen too much and
Okay.
speak up a little bit. Looks like
Okay.
there's a lot of noise on your end, but make sure that you are focusing on the screen and just
Okay.
seeing that. Okay? Thank you. Go ahead.
Okay. Anthropometry and dietary intake and screening tools. So weight loss. Unintentional weight loss 6% over 1 month, acute nutritional depletion, and biochemical markers are hypoalbuminemia and elevated C-reactive protein. CRP is 22 mg and active inflammation. And the function indicating compromised physical function. Upper arm circumference is of 22 centimeters. Dietary intake is oral intake less than 60% of estimated energy needs, exacerbating nutritional deficiencies. And the screening tools are PGSGA, that is patient generated subjective global assessment score. It's a 12. And GLIM is also we have used it for this tool. Next slide. Next slide, please. Nutrition diagnosis and intervention goals. Comprehensive assessment, a clear nutrition diagnosis was formulated to guide intervention strategies. So inadequate energy protein intake related to surgical stress and diabetes complications as evidenced by unintentional weight loss, hypoalbuminemia, and pure wound healing. The primary goals of nutritional interventions were promote wound healing, prevent weight or muscle loss, maintain glycemic control. So, crucial for recovery post amputation and the prevention of secondary infections, and the prevent weight and muscle loss to preserve lean body mass and improve strength for rehabilitation. And the GI control essential for reducing complications and optimizing metabolic environment for healing. Next slide. And the detailed nutrition intervention plan, a tailored nutritional plan was implemented to address the patient's specific needs, focusing on optimal macro and micronutrient delivery. The nutrient prescription route, oral feeding with the nutritional supplements due to the limited of intake. And the energy we have taken 30 to 35 kilocalorie per kg body weight. That means 2000, around 2000 kilocalorie in between 1900 and 2200 to support metabolic demands and healing. The protein requirement 1.2 to 1.5 grams per kg body weight to facilitate tissue repair and immune function. And the supplement support diabetes formula specifically designed to manage the blood glucose response. And the for collagen synthesis and antioxidant protection. Multivitamins also to address potential micronutrient deficiencies. And the fluid intake 1.5 to 2 liter we advised, adjusted the based on renal function and hydration status. Next slide. And the monitoring, evaluation, and recommendation for discharge.
Maheshwari? Maheshwari, I'm so sorry, but your voice is completely not audible at all. Maheshwari, can you hear me?
Nutritional interventions and guided the discharge plan.
All right, so looks like she dropped off. She's got a lot of network issues going on her end.
Hello?
Maheshwari, we cannot hear you at all. Nothing is audible. Looks like you are traveling or something. So
Yes,
please,
ma'am.
I would like to go ahead with the next presenter. We are just not able to hear anything from you, Maheshwari. It's not audible. You're not able to follow what you're saying, unfortunately. I'm so sorry. Okay, so if you could just go to a stable place and connect to a Wi-Fi, we will see if we have time at the end of the presentation, so you can go back and present rest of it, okay? All right. Thank you so much. And jury members, we will keep that for later and we will go ahead with the next presentation because I don't know if you were able to hear, but I couldn't hear anything. Were you able to follow? Ms. Varsha, Mitali or Bhakti?
No.
Yeah, actually, then I couldn't really, understand what she
voice
was
is not
talking
at all clear.
because,
Right,
yeah,
right.
not
So
at all.
let's
Yeah.
keep it for the end. And then,
Hmm.
Maheshwari, please make sure you get onto a Wi-Fi. We have 4 other people that we are going to go ahead and ask them to present. So you have some time to get to a secure place and get onto a Wi-Fi, okay?
Yeah, okay.
Thank you so much for your time. We will look forward for the rest of the presentation. So now we have Drishya for our next presentation. Drishya, are you on?
Yeah, ma'am.
All right. Okay. So you are on a Wi-Fi, right? On a laptop?
Yeah.
Perfect. Thank
Yeah.
you. So Sai, please go ahead and share Drishya's presentation. And Drishya, like I said, you'll have 12 minutes to make your presentation and 3 minutes jury members will have to ask any questions that they may have for you. Okay?
All right.
I'll remind you when it is closer to 12 minutes at about 11 minutes. And then you can wrap it up as soon as you can. And then we'll take the questions. Sounds good?
Sure. Yeah.
All right. Great. Go ahead.
Am I audible?
You are audible?
Yes.
Make sure you increase your volume
Yes.
a little more if you can.
Yeah, sure.
Perfect. Thank you so much. Go ahead. Good luck.
Okay. Good evening. My case study is on the topic post liver transplant with chyle leak. Next slide. Looking into the introduction, chylocystitis is defined as the accumulation of a milky or creamy triglyceride-rich peritoneal fluid due to the presence of intestinal lymph in the abdominal cavity. The pathogenesis of chylocystitis formation is related to a failure of the lymphatic system, which can occur after trauma or because of an obstruction or congenital factors. The most common cause of chylocystitis are congenital lymphatic abnormalities or various infections, malignant neoplasms, blunt abdominal trauma, cirrhosis, and abdominal surgeries such as inferior vena cava resection, liver transplantation, etc. Next slide. Looking into the patient's profile, my patient, 54-year-old male, was admitted on 19th of June 2024, and the length of hospital stay was 79 days. He was in underweight category according to his BMI was in underweight category according to WHO classification. Anthropometric measurements, height 168 centimeter, measured weight 56 kilograms. His dry weight was calculated because he had moderate ascites. A formula was being used to calculate the dry weight. It was found to be 50.4 kilograms and the BMI was found to be 17.8 kilogram per meter square. Ideal body weight was calculated using a Lemon's formula. It was found to be 62 kilograms.
Nutritional assessment. The tool used was a subjective global assessment, and the score was given B. No food allergies or intolerances were found. Date of screening and assessment was on 20th 6 2024. Next slide. Biochemical parameters. The main thing we can see the creatinine level were little fluctuating in the starting period because he has also got hepatorenal syndrome later, but it got stable too. Other values are completely getting normal only. Next slide. Medication and treatment. He was on CAP Pangraph, which is an immunosuppressant. It was found to have an interaction with the grapefruit and decrease the effectivity of the drug while having the grapefruit. So it was advised to avoid the grapefruit from the diet. Other drugs were not found to have any interaction. Next slide. Clinical data. Presenting complaints: abdominal distension, ascites, upper GI bleed, breathlessness, and fever. Currently admitted for liver transplantation. Past medical history: decompensated chronic liver disease with portal hypertension, type 2 diabetes mellitus for past 10 years, hypothyroidism, hepatorenal syndrome with acute kidney injury, surgery for renal stone in 2020. Medical diagnosis: decompensated chronic liver disease for living donor liver transplantation. Next slide. Diet history: 24-hour home recall. The energy was found to be 1,560 kilocalories, 220 grams of carbohydrate, 30 grams of protein, 55 grams of fat, and 28 grams of fiber. Food preference: currently, the patient is having non-veg foods, but was a lacto-veg before coming to the hospital. Food intake was moderate. Nutritional diagnosis: best statement: inadequate intake of protein from non-vegetarian sources related to religious beliefs as evidenced by patient verbalization. Inadequate oral intake related to food nutrition related knowledge deficit as evidenced by diet history. Inadequate macronutrient intake related to physiological conditions as evidenced by severe weight loss, muscle wasting, and diet history. Next slide. Nutritional intervention. Recommended total energy expenditure for post-liver transplant patients: 30 to 35 kilogram per kg body weight. Recommended carbohydrate: approximate 50% of total calories, 20% of total calories from protein, 30% of total calories from fats, 20 to 35 grams of fiber. The reference is given below. Next slide. So the MNT goals: short-term goals to maintain a reasonable weight to prevent weight loss, provide adequate protein to prevent muscle wasting, implement a fat-free diet along with the medium-chain triglycerides. Long-term goals: maintain ideal body weight throughout the life, continue a diet that provides adequate macro and micronutrients to maintain overall health and prevent malnutrition. Nutritional prescription according to the patient needs: energy 1750 kilocalories, carbohydrate 240 grams, that is 55% of total calories, protein 88 grams, 20% of total calories, fat 25 grams, fat 48 grams, 25% of total calories, and fiber 25 to 30 grams per day. Next slide. The pre-transplant nutrition was also assessed for the patient because before the transplant only, the patient was having chylous ascites. So the fluid triglycerides were checked in these days as given below. So the diet was kept a diabetic hepatic fat-free MCT-based diet because of high triglyceride levels in the chylous ascites. Oral nutritional supplement was used to improve the patient's overall health and to prevent further muscle wasting. MCT oil was used to meet the caloric requirements from fats. Next slide. Diet progression during hospital stay. So the date of surgery was on 20th 7 2024. POD 1 and 2, the patient was kept nil per oral. POD 3, diabetic clear liquids were started and then followed by diabetic high protein liquid diet. POD 4 and 5, diabetic high protein soft diet. POD 6 and 7, diabetic high protein low fat diet was initiated. And from POD 8 to 47, diabetic high protein fat free MCT based diet was being followed. The average of hospital recall is given below: 1,240 kilocalorie of energy, 179 grams of carbohydrate, 74 grams of protein, 14 gram of fat, and 20 gram of fiber. Next slide. The prescribed diet is given below: 1,700 to 1,800 kilocalories, 85 to 90 grams of protein. Diabetic high protein fat-free MCT-based diet was prescribed at the discharge time. Small frequent meal pattern was suggested. Protein dense options were discussed. Advice regarding using MCT oil in the diet. Next slide. Next slide, please. The comparison of hospital diet and prescribed diet with modified RDA. So while comparing the prescribed diet with the modified RDA, we can see it is meeting the needs and the requirements, and the average of hospital diet, we can assess that the oral intake of the patient was improving gradually at the time of discharge, till the time of discharge. Next slide. Concluding, Mr. 54 years old male patient came with abdominal distension and breathlessness with moderate ascites, planned for liver transplantation. Initially, the patient's oral intake was assessed and found to be inadequate. Considering his nutritional requirements, certain nutrient-dense options along with oral nutritional supplement was included to meet the caloric requirements. He was put on a diabetic hepatic fat-free MCT-based diet during pre-transplant because of chylous ascites found during ascitic fluid tapping, and triglycerides in ascitic fluid were found to be high. After a few days of transplantation, he was put on a diabetic fat-free MCT-based diet because of milky drain. To meet his protein requirements, egg whites, pulses, etc. were included in the diet. As days passed, his nutrient intake got better. During discharge, POD 47, the patient was advised to continue diabetic fat-free high-protein MCT-based diet. Drain volume reduced at the time of discharge. Discharge weight was recorded and it was found to be 56.4 kilograms. After a few days, the drain fluid gradually reduced and found to be nil. He was advised to continue the same diet for a few weeks more. On 29/10/2024, CT was done and no fluid collection was found. He was advised a diabetic high protein, low fat diet. Weight checked was 63 kilograms. Next slide. These are the references. Next slide. Thank you.
That's a very wonderful presentation by you, Drisha. Thank you so much
Thank you.
for putting all that work into it and also staying within your time. Good job. And now I would like to open it up for the jury members or anyone else.
Can I start? I just
Yeah,
had
please
Risha.
go ahead with your questions.
Yeah,
Firstly,
ma'am.
it's a wonderful presentation. Just have
Thank you
one
so much.
query. You said the patient was started on an MCT fat diet in the hospital, I think on day 8. I wanted to
Yeah.
understand how much was the MCT that you prescribed in your prescription, because I saw your average intake of fat during the hospital
Yeah.
stay was maximum, say, 13 or 14 grams. So that's what
Yeah.
I wanted to understand, that even if it was a fat-free diet with MCT, how much of MCT was added?
Ma'am, it was about 15 to 30 ml
15
per
to
day.
30.
30 ml.
Okay,
Yeah.
because the average doesn't show. I mean, whatever recall that you have showed on all days, it was showing only 13 or 14, or that's the maximum which is there in your hospital stay. Whereas in your prescription of the home diet plan, yes, there you
Yeah.
have mentioned about 30
Yeah.
grams of MCT or 30 ml of MCT. But in the hospital stay, at least in your recall, it was not there. That's the reason I had a query.
Yeah, ma'am. The MCT oil was not added into that, I think.
Not added.
Not added.
So then how were you meeting up with MCT fat? Because you said it was an MCT diet during the hospital. So
Yeah.
what MCT source were you adding during the hospital stay?
We were using, ma'am, Simile MCT oil here.
Okay. But you just mentioned that it was not being added. That's why I'm asking you. There's a confusion there.
No, ma'am. It was being added. I
Okay.
just forgot to mention it there.
Okay. So in your recall, you forgot to mention the total fat में MCT fat, right? So what you
Yeah,
mentioned
yeah,
is only the natural dietary fat which was coming.
yeah, yeah.
Okay. Okay. Fine. Yeah. Over to the other jury members if you all have any queries.
I have a question. It's a nice presentation. Any other comorbid beside diabetic the patient is having?
No, ma'am. He was
No
having, ma'am,
hypertension or?
hepatorenal syndrome also.
Okay, okay, okay.
I would like to ask two quick questions. Do you
Yeah.
check up on the frailty of such patients? Because it's a liver transplant case. So, do you check on the frailty? Yes or no?
No, ma'am. For that patient, no, because it is being started in our hospital.
Okay. And another question is because it was a chylus leak for so long days,
Yeah.
what used to be the volume, the maximum volume you saw? Because at the end it had reduced. So, what was the drain
Yeah.
volume?
It was around 500 and 600 ml, but it gradually decreased at the end of the time of
Okay. So,
discharge.
did you all use frailty or hand grip
Sorry,
for
ma'am, I can't hear.
use a frailty scale, the transplant patient, do
Yeah,
you measure the frailty? How frail the patients are?
ma'am, we started doing that, like the hand grip strength and those things. We are starting.
Okay.
We
So
have
we
not
have
checked at that time.
how frailty is measured, any kind of tool or just out of curiosity, I wanted to know.
Ma'am, hand grip strength is used.
Oh,
There is a machine to just
yeah,
check it.
yeah. All right. Thank you.
Thank you, ma'am.
Good explanation for whatever
Thank
you
you
have.
so much.
Yeah, Deepthi, we can go to the next presenter. I think we are done with our questions.
Okay. Esther, do you have anything to add?
Yes, Dipti. Hi, Drishya. Thank you for your presentation. Very nice.
Thank you so much. Thank
I
you.
just have one quick question. Why was the LOH so high for a liver transplant? Any thoughts on that?
Sorry, ma'am.
Why was the LOH so high? It was almost 50 days, right? 49 days or something.
Yeah.
LOH, yes.
Yes, ma'am.
So typical length of hospital stay for a liver transplant case is
Yeah.
not so high, isn't it?
Yeah.
So any particular reason why it was?
Ma'am, it's because only of this sky leak only. The
Yeah.
patient was put on this diet and it should be like cured. Then only he could be discharged.
So
That's
see,
why the
Kylie,
hospital.
yeah. So I think you need to think a little bit more on that because see, Kylie is not exactly a reason to keep the patient in the hospital.
Yes.
Patients can actually get
Yeah.
discharged with Kylie. Second point I
Okay.
wanted to add on to what Varsha said is, see, when you have patients who are on such a long hospital stay, it is
Yeah.
worthwhile to do assessments for sarcopenia and frailty.
Yeah.
You have used SGA, but
Yeah.
it will be good if GLIM can come in, if you have body composition analyzers, hand grip, simple
Yeah.
functional outcome measures, especially for this, long hospital stay patients. Apart from
Yeah.
looking at just weight as an outcome, it will be good if
Yeah.
you can look at functional outcomes because that really will matter in terms of nutrition interventions.
All right,
Otherwise,
ma'am.
good presentation, good flow, and best
Thank you
wishes.
so much, ma'am.
Thanks.
Thank you, ma'am.
Yeah. Good job, Trisha. Thank you so much
Thank you
for
so
taking
much.
time out and presenting. And we move on to our next presenter. Her name is Sai Darshini. Darshini, are you ready?
Yes, ma'am, I'm ready.
All right, you're on a Wi-Fi, you're on a
Yeah,
laptop, it's a stable connection. Just make
yeah,
it, okay?
yeah, sure, ma'am.
Awesome. So before we begin with Darshini, Anita James is our next presenter. Anita, please be ready with your laptop and your internet connection. So we can have this as a seamless experience to our people who are joining us today. All right. So, Sai, please share the screen for Darshini's presentation. Darshini, your time starts now. It's 4:40. You have
Okay.
12 minutes to do your presentation. Please use your time wisely. And after that, the jury members are going to ask you some questions.
Okay, ma'am.
All right.
Okay, okay, sure. Yeah. Good evening to another person here. So myself, Sai Dashni, a clinical dietitian in Bilroth Hospital. So, okay. So my topic is chronic cirrhosis with ascites. So shall I move? So next slide. Yeah. So this is the patient profile. His age is 47. The gender is female. His economic status is also lower, and his dietary pattern is non-vegetarian. The length of hospital stay is almost 32 days. So next slide. This is the clinical assessment for the present complaints. He has a known case of pulmonary hypertension with now he is admitted for the liver cirrhosis with the cause of severe ascites, distension since 4 months, and then other symptoms of pedal edema, and then poor appetite, loss of weight, weakness and shortness of breath, and dyspnea, and heaviness of chest present. And the past medical history, the 17 years back, she has a fluid accumulation in abdominal during the post-pregnancy duration, and he took some Ayurvedic medicine and it will settle down. And the final medical diagnosis is liver cirrhosis is ascites, and diluted cardiomyopathy is his final diagnosis. Next slide. Okay, this is the quick intro about the liver cirrhosis. So cirrhosis is the condition which liver lost the deterioration and unable to function normally due to the chronic and long-lasting injury. And it will have to the worsen the tissues, replace the healthier tissues. This block the flow of blood through the liver. So main causes of liver cirrhosis is one of the chronic alcohol intake or hepatitis B, and hepatitis C is the main causes, and it may also lead to the end stage of liver disease. Next slide. And this is the pulmonary hypertension. With the liver disease can cause portal hypertension, which increases the blood pressure in the vein and enters the liver. This increases the pressure, causes of blood to bypass of the liver. The pulmonary artery, which is responsible for transporting the blood from the right ventricle of heart to the lungs, and it narrated and blocked due to the disease. So the pump of the blood, the heart needs to work harder, but because it is enlarged and weaker, so it is increases the suffering of heart failure. Next slide. And it is the diluted cardiomyopathy. It is, and this is related to the heart muscles. The heart's ability to pump blood is decreased because the heart main pumping chamber's left ventricle is enlarged, dilated, and weaker. And it is an ascites. So ascites mechanism is developed in a cirrhosis is multifractional. See, and then she has a severe portal hypertension, and hepatic insufficiency is the initial factor. This may lead to the circulatory dysfunction, characteristics by atrial vasodilation, atrial hypotension, and a high cardiac output, and hypovolemic and renal sodium and water retention. Next slide. And this is the malnutrition. The patient with the cirrhosis frequently have either the global nutrition alteration in a specific aspects of nutritional status, such as micronutrient deficiency, due to the multiple mechanism, including the poor nutritional intake, poor absorption, and increases the losses. Next slide. And this is an anthropometric measurement of my patient. The height is 147 and the weight is 37. The BMI is 15.7, which is an undernourished, and IPW is 47 kgs. Next slide. And this is an from the hospital stay, from the starting to end, we calculated the abdominal girth, and then fluid input and fluid output, and then this is an ascites tapping were done in 3 days. This 3 days. Next slide. Next slide. This is in biochemical parameters. The hemoglobin from the initial stage is much low, which is then 7.5, and gradually it will increase, but not that much. And then SGOT, SGPT is also quite normal, and urea creat is also fine. So this is an entire biochemical value we taken. Next slide. And this is an other investigation, which is an temperature, pulses, and then respiration, and then blood pressures. We are frequently monitoring the patients. Patient. Next slide. Next slide. This is the medication we given for the patient for this condition. I'm not going to read this and all because it's quite long. Next slide. This is the 24 hours dietary recall. I think we can go ahead with the interpretation. I will share in the next screen. So next slide. Okay, the energy is 842 kilocalories, and protein is 16 grams, and carbohydrate is 135 gram. The fat is 29, and sodium is 92.6 gram. So interpretation shows that the recall of it is a large gap between the meals, and the protein intake is also much lower. So no cereal pulses combinations were included. So total calories is 842. The 180 will come from the biscuits. So no fruit consumption in the diet. This is the interpretation of 24 hours dietary recall. Next slide. And this is the nutritional assessment. For the BMI, it is an 15.73 kg per body weight. Meter square. It is then severely undernourished. Next slide. Okay, this is the presence of the mild to the moderate edema and severe ascites with a poor food intake. The severe loss of functional status, strength, and stamina indicate the patient is undernourished. The low hemoglobin include the presence of anemia, and then hence to provide optimal iron through the diet and nutritional supplements. Include the sources of vitamin C in the diet to enhance the absorption of ions. Next slide. And this is the medical nutrition therapy. The energy we are given is 25 to 40 kilocalories. And then Epson, it is then 35 to 40 kilocalories per body per day. With acute encephalopathy, it is then 35 kcal. Without encephalopathy, it is then 25 to 35 kilocalories. It depends upon the patient's BMI ranges. Next slide. And then protein, the cirrhosis is a catabolic disease which increases the protein breakdown, and inadequate resynthesis is depleted status and muscle wasting. The negative nitrogen balance due to the protein restriction lead to the protein energy malnutrition and decreases the severe rate in a patients with liver cirrhosis. So it is almost 1 to 1.5 gram per body weight. And then next slide. And then carbohydrate. The carbohydrate is the major source of calories in diet. The fasting, the lower blood sugar can occur because of decreases the ability of glucose to glycogen. Therefore, the carbohydrate should be provided most in the non-protein calories. And then lipids, it is an excessive dietary fat may encourage the cirrhosis of progression. The high intake of total fats, saturated fats, and then a PUFA where has been implemented. The MCT should be included in the diet for liver cirrhosis. It is better to tolerate the patient absorption and the absence of bile. Next slide. Okay, and then antioxidants and B vitamins. The cirrhotic patients have significantly reduced the antioxidant enzyme and antioxidant nutrients such as carotenoids, selenium, vitamin E, and zinc. The deficiency of folate is also found in liver cirrhotic patient. Estimated that 50% has increased the blood, which is caused by liver fibrosis and ultimately in a liver cirrhosis. And then it's a hepatic, it is an osteopenia can also develop. So therefore, vitamin D deficiency supplement is also necessary. Next slide. And then sodium restriction is much needed. The diet low in sodium can help to treat ascites, edema. So it is minimize the amount of salt and entering the kidney and leaving the loss of sodium ability to reabsorption. Therefore, the less fluid is retained. So 2000 mg of sodium restriction diet is effective. Next slide. And then the fluid monitoring should be calculated, which is an electrolyte and fluid balance. In liver disease, the blood vessels ability to retain the fluid and demands because of decreases the protein synthesis in liver, mainly the albumin. Next slide. And this is the case progression. From the day 2 to day 17, we provide the soft hepatic salt restricted diet. And day 18 to day 31, we provide the full hepatic salt restricted diet. So next slide. Okay, this is then short-term goal for the management to treat the symptoms and prevent the complication, and to prevent the progression and management to them, to administer the fluid and sodium retention to prevent the further complication, to slow the progression of the scar tissues, to correct the nutritional deficiency if any, to provide adequate nutrition to prevent macro and micronutrient deficiency, to provide adequate protein with a high biological value to ensure anabolism, to maintain, to prevent protein breakdown for energy synthesis, to provide frequent small meals to reduce the patient's discomfort. Next slide. Next slide. Okay, this is an hospital diet we provide for the day 2 to day 17. The type of diet I already mentioned, which is a soft hepatic diet. We will split into the eight meals per day. The consistency is soft. The energy is 1052 kcals, and the protein is 39 gram. Carbohydrate is 165 grams, and fat is 26, and MCTs is 10 grams, and sodium is 431. The salt per day is 4 gram per day, and the fluid is 1000 ml per day. Next slide.
Actually, you have one minute to finish it up.
Yeah, sure, ma'am.
Try to wrap it up soon as we can.
Yeah, okay. And this is then a diet plan for a soft hepatic diet. Next slide. Next slide. And this is then full hepatic diet, which is then this meals also we distributed into the 8 meals, and then calories are also I mentioned here. Next slide. So this is the full hepatic diet. I give the reference. Next slide. Next slide. Okay, next slide. Okay, this is the nutritional complications. From the initial stage, their patients have loss of appetite and not willing to eat food. Later, we provide some nutritional counselings. It will increase the food consumptions. Next slide. Next slide. Okay, this is a long-term goal to provide adequate nutrition to prevent macro and micronutrition deficiency, to prevent progression and complication and manage them, to slow the progressions of scar tissues, to administer fluid and sodium retention to prevent further complication, to prevent nutritional deficiency also. Next slide. And this is then full hepatic diet discharge for the calculation range is also I mentioned here. Next slide. Next slide. Okay, this is the food exchange list. I have been splitted according to the patient's portion control. According to this, I will plan some menu also. Next slide, I will show it. Next slide. Yeah. For this slide, I will menu. I will according to the exchange list. I prepare the menu for a prescribed for the diet to her. Next slide. Next slide. Okay, this I give some dietary alternatives for also here. Next slide. Okay, the fat calculation, the fat allowances is 31.275 grams, and visible fat is 20 gram, and invisible fat is 11.72, and MCTs are 10 grams were given. Next slide. And this is then the range we provide the MUFA, PUFA, and then omega-3 and omega-6 fatty acids. So these are the some ranges I were mentioned here. Next slide. So okay, these are the supplement we given for the patient. Next slide. Okay, this is the recommendation. The frequency of meal, the consumption, the small frequent meal instead of consuming the large meal, having a 5 to 6 meals. Method of cooking I mentioned here, and milk and milk products is must be the skimmed milk, which is an heating and cooling by stored in the refrigerator immediately. So this is I mentioned here. Next slide. And then salt intake, it should be a 4 gram per day. So we provide without salt diet. After that, we have to give the separate 1 gram salt, and it will add it to the diet. So this is I mentioned here. Next slide. And this is the fluid and beverages to monitor the daily fluid intake to for this do not exceed your fluid intake. So it in liquids include the water, milk, juices, and other beverages. The 1 cup of water is like it should be at 250 ml. And then exercise is also lifting less than 10 kgs were recommended. And then walking is also much needed for the blood circulation. Next slide. Next slide. Okay, this is an ARF recipe which I given for the patient while discharge. Next slide. Okay, this is an OPD follow-up. Since she is symptomatically better and hemodynamically stable, his appetite has improved and was eaten well. There was increasing the patient body weight as 1.5 kg, and there is a no abdominal discomfort, organ wear, and then abdominal girth is also 63 centimeters. And dietary recommendation were reinforced to the patient, and certain strategies of making meals nutritionally dense were discussed. So next slide. Thank you.
Hi, Darshini.
Yeah, ma'am.
Yeah, this is Varsha. So, of course, your presentation you had to rush because of the time was not adequate.
Yeah.
I have a few set of questions, but I'll give the liberty to other judges also. Maybe they want to ask.
Okay.
So, two
Okay.
quick questions. You moved your slide quickly through the supplementation. I wanted to understand what type of supplement you gave and
Yeah.
what was the calorie composition, calorie and protein. Why did you choose that supplement?
What, ma'am? I'm not audible.
What type of supplementation you gave to your patient? Because you moved
Yeah,
through
for
that
this
slide very
treatment,
quickly.
I give the multivitamin gold and zinc weight supplement. For this, we have a lot of amino acids present in that supplement, so we provide it.
Anything to boost the calorie and protein?
No, not much, but we have to focus on micronutrients, so that's why we
All right.
choose it.
Okay. Second question. I thought I missed whether you had mentioned about your PES statement, problem etiology, sign and symptoms. So what do you think is your PES statement for this?
Yeah, ma'am. Patients has like abdominal discomfort. Sorry, I'm not able to mention. So he have abdominal
You can
discomfort.
speak up.
Yeah, and then like he have like chest discomfort is also she have.
Okay. Maybe other judges can take it up.
Yeah, Darshini, I have a question.
Yes,
Like Varsha said, you said that initially the patient's oral intake was not sufficient. So
yeah.
you didn't go for any food supplement to make up the calories and protein?
No, ma'am.
Any specific reason why it was not, you have not?
I know the patient is not willing to take supplements, so that's why we won't
Okay,
provide. So because that why we provide some tryptophan biscuit also. So that's only we
okay,
provide.
okay.
Yeah, ma'am.
Next judge can ask any question.
Yes. Anyone else have any questions, Mitali or Esther?
Question, but a suggestion. Like, yes, you did mention about guidelines for sodium, where you
Yeah,
give
ma'am.
2000 milligrams. I mean, that's the guideline. But I think in practice, even for normal individuals, the guidelines for sodium have come down. Even for normal individuals like us, where we recommend, say, 5 grams of salt, someone
Right,
with
yes.
ascites, someone with a fluid restriction of a liter. I
Okay.
know as per guidelines, you've mentioned it that you have to give 5 grams, and that's the reason you are giving 4 grams, and the remaining 400 grams of sodium is coming from the natural dietary sources. But with a liter of restriction of fluid, the salt intake will go further down.
Okay.
Yeah, you will have to maybe, tighten up your sodium restrictions a little bit. Um,
Okay, sure,
yeah,
ma'am.
and use other alternatives to enhance the flavor in the food, and not
Okay.
make necessarily that 4 grams of salt. So that
Okay,
was
okay,
just.
sure. Okay, I'm sure, ma'am. Thank you.
we can move to the next presentation. Deepti, you're mute.
Sorry. I have bad cough, so I'm trying to mute myself up so you guys don't hear my cough. Thank you so much, Darshini, for that wonderful presentation. Anyone else have any questions, judges? Esther? If not, we are going to go ahead and move on to our next presentations. I don't want to delay this any further, keeping in mind the time. So our next presenter is Ms. Anita James. Anita, are you on?
Yes, ma'am.
All right, thank you so much. And are you in front of your computer, ready to go?
Yes.
Perfect. Thank you so much for being prepared. And next we have Amrita. Amrita is our last presenter for the day. Amrita, please be ready with your computer. As soon as we are done with Anita, we will move on to you. Anita, like I said, you have 12 minutes. Please stick to your timeline because we don't want to run over and want to give fair chance to others as well. Go ahead with your presentation. Good luck, and we are looking forward to hear from you. Sai, please share your screen, and here we go. Go ahead, it's all yours. I'll remind you when it's 11 minutes, and then please wrap it up as soon as you can. Okay?
Good evening, all. Myself, Anita James, dietitian trainee from Cathas Hospital, Kottayam. Today, I will be presenting a clinical case study on coronary artery bypass grafting, also known as CABG. Next slide, please. Hello, next slide. Okay, next slide. Okay. Previous one, please. Next one. Okay, CABG, coronary artery bypass grafting, is a clinical procedure used to improve blood flow to the heart in patients with severe coronary artery disease. It works by grafting a healthy artery or vein from body to bypass blocked coronary arteries, which provide restoring oxygen-rich blood supply to the heart muscle. The surgery is often performed in cases where multiple arteries are blocked, as in our case today, which involves triple vessel disease, that is CAD with triple vessel disease. So we have done the CABG. Next slide, please. The causes for CAD is smoking, high blood pressure, high cholesterol, diabetics, and sedentary lifestyle. Next one. Symptoms for CAD is chest pain, heaviness, tightness, burning, squeezing, shortness of breath, sweating, dizziness. Next one, please. Next to the case. Our patient is 55 years old. He's from a middle income group. Next one, please. Next one. With a normal BMI of 22.5 kilogram per meter square. Next one, please. We have done SGA. SGA was A, like he was nutritionally stable. Next one, please. Next one. Okay. Biochemical parameters. For first 2 days, HB was normal, and then for 3 to 5 days, HB was alternated. And next one, please. RBS, his random blood sugar has increased. Next one, please. Clinical data, presenting complaint was chest discomfort and breathing difficulty. Past medical history was coronary artery disease and with type 2 diabetes mellitus. Final medical diagnosis was coronary artery disease with the triple vessel disease. Next one, please. Next one. This is where the medication is given. Next one. This is a 24 hours recall. And next one, please. This is a foot frequency table collected from the patient as for 1 week. Next one, please. Holter, he has got adequate energy, protein, and fat from his 24 hours foot recall. Next one, please. Next one. Okay. This is the first hospital recall. We have given 2 times supplements to provide enough protein for 3 days hospital stay. Next one, please. Next one. Okay, next one also. Next one. Next one also. Next. Okay. Pest statement. According to his condition, damaged the major blood vessel of heart and increased blood sugar level related to sedentary lifestyle. He was also alcoholic abuse and smoking, and he was having poor food choices as evidenced by chest pain, diet history, and hypoglycemia and fatigue. This was his problem, etiology, and signs and symptoms. Next one, please. Goals. To promote wound healing process, to maintain optimal nutritional status, and to reduce the blood sugar level, to maintain ideal body weight. Next one, please. Principle of diet. Have provided high calorie, high protein, moderate carbohydrate, low fat, and high fiber food. Next one, please. Next one. Okay. This is the planned menu for the patient. I have given soft diet. Next one, please. Okay, have reached the calorie, protein, and fat. Okay, next one, please. Okay. This one is the comparison of hospital and prescribed diet with modified IDA is given below. Next one, please. Next one. Okay, next one also. Next one. Recommendations. I've provided small frequent meals as was suggested, and complex carbohydrates like whole grains, like whole wheat, unpolished dried ragi should be taken. Small carbohydrates like sugar, sweet, jaggery, honey cake, juices should be avoided, and starchy vegetables like potato, tapioca, sweet potato, etc. should be restricted, and refined cereals should be completely avoided. Then intake of protein should be increased as it helps in wound healing. Pulses like green gram, red gram dal, lentils, etc. should be consumed. High biological value proteins like egg white, fish, chicken, egg, meat, milk, and milk products should be consumed. Fat consumption should be reduced, and the majority should come from essential fatty acids. Essential fatty acids like fatty acids should be restricted. Steamed foods are better than fried foods. Vegetable consumption should be increased as it is rich in fiber and helps to control the blood sugar level. It's also rich in vitamins, minerals, and antioxidants. Home cooked foods are recommended. Junk foods should be avoided, and ask them to carry a chocolate, which helps in hypoglycemic episodes. Next one, please. Okay, this is a sample of food chart given. Next one, please. Okay. Conclusion. The patient, post-surgery, the patient diet progressed from liquid to soft solids with improved intake at discharge. A high protein diabetic diet was prescribed, and to aid recovery and prevent complications. This case highlights the crucial role of medical nutrition therapy in post-CABG recovery, particularly in diabetic patients. Next one, please. Thank you for your attention. I'll be happy to answer any of the questions. Thank you.
Thank you so much, Anita, for your presentation and making sure that you are mindful about the time. That counts as well. And I would like to open it up for our jury members for any questions that you may have.
So I think in the interest of time, instead of asking questions, I have a lot of suggestions for you. So first and foremost, Anita, the case that you were presenting was of a coronary artery bypass. Now, the common sense says anything to do with heart, a bypass, a low-fat diet. But while you're counseling your patients, when you take a medical history of your patient, when you take a dietary history of the patient, you have to try and understand what were the causative factors for that particular patient and then guide your medical nutrition therapy accordingly. You put the home recall. You've written the carbohydrate, proteins, fats. You said that it met with the requirement. Then why do you think that the patient landed up getting a a cardiac problem and had to undergo a bypass, right? So it's not about only the macros. Within the macros, you need to look at the components. So when you do your dietary recall, it's very, very important that you look at from where your macros. So what type of fat was coming, or what type of carbohydrate was coming, or how much was the first class protein. In terms of fat, was there a higher percentage of saturated fat versus, the polyunsaturated fat? So based on that, you will be able to, guide the patient better. So that, okay, there was a problem, we sorted the problem, doctor did a surgery, but you know that if not taken care of, again, there can lead to multiple other problems. So that part. When you're showing your dietary recall, home recall, or your hospital recall, you're putting it as numbers, carbohydrate, protein, fats in terms of numbers. These numbers mean nothing if you don't put a percentage, right? A 200 grams of carbohydrate can be normal also, or can be very high in terms of percentage depending on the calories that the person is consuming, right? So all the guidelines which are given with percentage. This much percentage of carbohydrate, or this much percentage of protein, or this much percentage of fat. And especially for your coronary artery bypass patient, your fat, your visible fat, your invisible fat, from where your fat is coming in the diet, how much is coming through invisible fat, how much is coming through the processed fats. So I think understanding that in your assessment is very important. So I think that was one part. And even in your MNT, when you showed, you have stepped up from a patient consuming 1100 calories to a 2000 calories. Maybe on paper it's correct. Maybe on paper it's correct as per the guidelines. But you have to understand, how do you step from 1000 to 2000? It's a complete 100% increase, right? You're going to double the increase for the patient. So it's okay, you can show a target. But at the same time, you can show in your medical nutrition therapy that you've been able to provide only, say, 70% of your target to start with, and then you slowly step up. So I think these things are important. So what you present, how much you emphasize on which aspect you emphasize on, it makes it's very important depending on the case. So there were few things which I thought you could have elaborated a little bit more on. So these were the things which I thought were missing in your presentation. So that's all from my end. Over to the other jury members.
Thank you so much, Bhakti. That's very comprehensive feedback from you. Mithali, Varshna, any
Yeah,
of you?
she has already asked, advised what was I also thinking. So from my side, no question. But just want to know, she said she was giving a high calorie diet. So if the patient is diabetic, so are you monitoring the blood sugar since you are giving a high calorie diet to a patient?
High calorie and high protein also, ma'am. Protein and
Yeah,
fiber
yeah,
rich food are
yeah.
given.
Are you
So are
sugars?
you monitoring the blood sugar during the phase, because you have given a diabetic patient a high calorie diet? So I just want to know how was the sugar level during the hospital stay?
First day it was 300 above. Then onwards we just monitored, and then
Patient was on
discharge
insulin?
day partial sugar was 130.
300 and
Okay.
130.
So at the time of discharge also you have gone for a high calorie diet, or so you have cut down the calories?
No,
Protein is okay
moderate
for
calorie,
high
high
protein.
protein, and high fiber, ma'am.
Okay, okay, okay. Thank you.
Right.
Hi. Just a quick observation. I do agree with certain Bhakti's comments. My questions are two. One, why did you choose this case? CABG is so common. And second thing means, what was interesting for you to choose this case? And the second question is, what is the follow-up plan? Because if you look at CABG, it is a major surgery. Okay. So what is the follow-up plan in like two major advices in follow-up? How do you do your follow-ups for CABG patients?
First, I took this case because his blood sugar was higher than other patients I have seen. And the next follow-up, I would say him to like maintain the same dietary pattern, and to reduce the fiber to moderate fiber he can consume. Like that
Can
every
you suggest how much, what do you mean by moderate to average fiber? Like in grams, the type of fiber? You had planned 2000 calories, or you had planned 1000 calories. So what was your MNT for fiber?
24 fiber, it's 20, like it's 20 to 30 grams.
All right. Fine. And was the patient on insulin or medication?
He was on insulin, then started with 2 OHA.
Okay. Fine.
Okay. Thank you.
Okay. Thank you so much, jury, for the feedback. So in the interest of time, I'm just going to move on for the next presenter. Thank you so much, Anita, for your presentation. And the last presenter for the day is Ms. Amrita. Amrita, are you ready?
Yes, ma'am.
All right, thank you so much. And your time starts now. You have about 12 minutes. Please be within your time range. Yep, that's your presentation. Go ahead, it's all yours.
Next slide. Good afternoon to all. Today I'm going to present a case study on the severe head injury on GT field. Next slide. The patient taken for the case study was 56-year-old man, and the weight of the patient is 53 kg, and the height is 169 centimeter, and the BMI is 80.5 kilogram per meter square. The BMI is in borderline, and the patient having the chance of weight loss during in this particular condition. And next slide. Next is the biochemical data. The table shows that the patient having the low hemoglobin level at the day 1, and for the day 2 it will be improved, and the WBC count also increased. That means that the patient having the infection. Next one. And next one is the fasting blood sugar. Sorry, next previous slide. Fasting blood sugar shows that the patient having the increased level during the day 2 and 3. Next one. Next is the other investigation. Here the blood pressure is low, and the remaining values are stable. Next one. And next is the clinical data. The patient having the present complaint. Patient is a post-RTA condition, having a severe head and chest injury with a past history of diabetic and hypertension. And the medical diagnosis and the treatment are the cranioplasty. Next one. Next slide is the medication. The patient using hypoglycemic and the antihypertensive drug for managing the diabetic and hypertension condition. And next one. And also use the antibiotic analgesics, etc. Next one. Next is a nutritional calculation of the home diet recall. The patient getting only 9,048.8 kilocalorie of energy and 46 gram of protein, and 125.9 gram of carbohydrate and 24.8 gram of fat, and it is deficient to the patient. Next one. And next is the 3 days hospital diet recall average, and the patient is on a peg feed. Day 1, day 2, and day 3 are remaining energy, same energy, protein, carb, and fat. The protein is 1,046.6 kilocalories, 78.72 gram of protein, 157.8 gram of carbohydrate, and 9.96 gram of fat. Next one. Next is the nutritional diagnosis by statement. The only gastrotract feed is tolerated to the GI system of the patient related to the oropharyngeal dysphagia, as evidenced by the history of severe head and chest injury, and severe weight loss observed related to the long-term GT feed, as evidenced by the anthropometric measurement. Next one. Next is the principles of diet and MNT. Moderate calorie and moderate carbohydrate, high protein in peptide form, moderate fat and high vitamin C, and moderate amount of sodium are prescribed. Medical nutrition therapy, a diet with moderate calorie, moderate carbohydrate, and high protein diet is especially albumin is recommended for the patient for maintaining the managing the weight loss, etc. And take the protein in peptide form because the patient having the digestive issues, so that's why we are using peptide form. And for the better wound healing, etc. Restricted the sodium intake because the patient having the hypertension condition. Consider low glycemic index and low glycemic load before menu planning, and plan feed by using sugar-free supplements only. Next one. Next is the detailed prescribed hospital menu. The patient getting 1527.1 kilocalorie of energy, 79.5 gram of protein, and 209 gram of carbohydrate, and 42.4 gram of fat. That means 55% of the total calorie is carbohydrate, and 25% of the total calorie is the fat. Next one. This is the table shows that how much of energy, carbohydrate, and protein which get from the supplement. Secondarily, 200 ml of feed was given to the patient. Mainly peptide-based supplement was given for the better digestion and absorption. And a dietary fiber supplement was also given to the patient for avoiding the digestive issues. And next one. Next is the comparison percentage of difference planned menu minus prepared menu divided by the planned one into 100. Here for the energy, 1527.1 kilocalories is the planned one, 1670.71 is the prepared one. There is a minus 5%, 5.93% of difference. For carbohydrate, 5.68 gram of difference. For protein, 7.13 gram difference, and fat 2.24 gram. Next one. Next, good quality protein like peptide supplements are recommended. Probiotic supplements, endogermina should be included in the diet. Avoid roots and tubers in the feed. This will help to reduce the bloating and GI tract and maintain the blood sugar level. Example, potato, yam, tapioca, etc. Plain and empty calories, etc. Example, fruit juice, syrup, and table sugar, etc. should be avoided in the feed. Iodized salt is suggested for the patient. Sugar-free supplement will be advised. Next one. Monitoring and evaluation. Peg feeding is continued. Second hourly 200 ml is given now. Earlier it was 150 ml. Proper diabetic and high protein feed is followed. Thank you, ma'am.
Thank you. Thank you so much, Amrita.
Okay.
Sticking to your time and with the presentation. Is this your last slide? Was that your last slide?
Yes, ma'am.
Okay, good. Thank you so much. Just making sure that you finish all the slides. Any of the jury members have anything to add?
I'll just quickly make few comments and then I request my other jury members to ask questions.
Okay.
So I noticed in her dietary recall, all 3 days recall was just cut, copy, paste. Like how can you have 1078 and 78 grams of proteins? So if you have some understanding and explanation, you can do that. And related to supplements, probably recast questions. There's a little bit of noise around, so I'll just connect in a few seconds, but I'm online.
Okay. So you can answer the first question, Amrita. About the You didn't understand the first question about the protein. She was asking about the protein.
So your diet recall said that all 3 days you had the same intake, 1078 and 78 grams. So all 3 days, just same.
Ma'am,
And then we take average.
ma'am, we prepared supplements and given to the patient. So it's that energy and 1 gram, 1 scoop of 1 scoop of this protein will give this much of energy and protein. That's
So basically what you're saying is patient was on enteral feed, so whatever you had actually planned for was administered and there were no miss outs. And the patient tolerated everything.
yes.
Right? That's what you're trying to say?
Yeah, ma'am.
Okay. Okay. So, frankly speaking, Amrita, I thought the case was just so the initial part that you presented, but I thought the information presented was not enough. It could have been a little more of information, little more of interpretation. Then it would have maybe given a good learning and a good feedback for everyone who's there. So the basic idea of doing a case study is to understand in a particular case how you first interpret the problem and then do your medical nutrition therapy and how exactly you monitor. But that is what did not come out very clearly. Okay. So I thought it was half presented. I think I was expecting a little more. So I think that that's the reason I have very little few comments, to give you on this. So maybe a little more of monitoring, a little bit more on trying to understand the tolerance, or maybe okay, the patient was only for so many days. What is your future plan for this patient? Right, depending on what physiotherapy the patient is undergoing, or what other therapies are going to be a part of the treatment, and based on that, do you think you want to escalate your planning or your intervention? So that part could have added more value. So I think I would just stop here. Over to
Right. So that's just some feedback, Amrita, from the jury members for, when you present your next case studies, just keep that in mind. All right. Yeah. So thank you so much for the presentation, Amrita. I'm guessing that no one else have anything to add. Dali, are you going to say something?
Yeah, the presentation should be a little more informative. Informations are a little less. So, what she has said earlier, jury, remember, I also suggest for the same thing. It should be little more informative.
Okay.
That's all.
All right. So, yeah, so pretty much all our jury members are resonating the same message that they were looking for a little more information.
Dipti, sorry to interrupt. I just wanted to check with you. Have the way we have been given, the juries have been given the evaluation, are these pointers shared with the students or the dietitians who are presenting? I think if you share that with them, they will also understand what exactly is expected out of them. So
Correct.
it gives them a standard way of presentation. And if at all, for any reason, see, because each hospital will go in with a different flow. And some students are still learning, some are undergoing internship, not yet completed. So I think if you give them the way we've been told to grade them, if at least those heads are given to them, I think then the presentation will be more uniform, and maybe they'll try and put in all the efforts and data which is actually needed. So that would just be a feedback for y'all, if at all y'all have not done that. Yeah.
Yeah. There are some guidelines that we have given, but I think it can be improvised. Maybe like a template that can just fit everybody into the same norm can be done. Yeah, that's a great idea. I was thinking on similar lines as well, Bhakti, that this has to be standardized so we have the same thing for every presenter. Yeah, that makes sense.
I think there's a learning for them also.
Yeah.
Because there are no miss outs, and then they will also start thinking in that manner that okay, these are the steps that are supposed to be doing, irrespective of whether you're presenting or not presenting.
Correct.
So they will make sure that they dig into those details and present that.
Yeah, I agree. Yes, for next time, definitely something that I'm going to keep in mind and make sure that we share that information with it. Kiran, you have something to add?
I just wanted to share that we had communicated to everybody a particular template, and the template is the basis on which even the jury, marks are being awarded. Possibly, maybe we need to give a little more descriptive details, make it more easier for them to understand.
Yeah. Thank you, Kiran. All right, so just wanted to say a note to all the presenters. So the feedback that the jury is giving or anyone is giving is just to make these presentations much more, meaningful, and more learning can be done through this. Or, it's not any sort of like pointing or anything like that. We all learn, and, even after so many years of practice, we are still learning new things every day. That's the goal. Learning is the goal. So make sure that you take this positive feedback, and then when you're presenting next time, we can have that included. And from our side, we will see how better we can make it. So I believe that's all for today's presentations. In the interest of time, I was hoping Maheshwari's presentation to come back up, but we will see how we can plan that presentation because, she couldn't present today. We will talk to her and see what we can do on that front. But for now, I think that's all for today. It was wonderful presentations by all our presenters. And thank you so much for taking time and making presentations and participating in this case study contest that has been conducted by Nutri Health Foundation, sponsored by Pulse NutriScience. I also would like to thank all our jury members for taking their time out from their busy schedules and sitting here listening to all these presentations very patiently and giving us wonderful feedback that can be a great learning for all these presenters. I'm sure that it's going to be very helpful for them in their future. I also would like to thank Kiran from and the Pulse NutriScience team for sponsoring this event. It's a great initiative, and it's a privilege for NutriHealth Foundation to be hosting these case study presentations on our platform. Thank you so much, and we will communicate the results and next steps in our social media posts and also through our individual communications. Thank you, everybody. This concludes today's case study presentations. Kiran, is there anything that you would like to add?
Thank you, Deepthi. I think it was a very good educative and informative sessions that we have had today. I'd like to thank on behalf of Pulse NutriScience, all the presenters, the jury for taking time out and giving such insightful feedback. I'd also like to thank Dr. Esther for having joined in and staying through the presentations. And thank you, Deepthi, for taking through the entire sessions. I think we have had some learnings from this session in terms of both at the technical end and even in terms of how we can support the next set of contestants to come out with a better case study presentation. Maybe we can make some changes for the next month's edition.
Definitely.
Thank you, everybody, for your time. And it was a pleasure to host such events with the NutriHealth Foundation, where we can work as a partner to improve the nutritionists' knowledge and help better the overall delivery of nutrition to our patients. Thank you very much.
Thank you, everybody.
Thank you, everyone. It was a nice session.
Thank you.
Thank you very much.
Thank you.